if we can use myself in this example again, like some pelvic floor muscle issues due to sporting in my 20s, then 2 babies later. It's like adding stripes to a tiger a little bit. And then I was sick for the last month. So that coughing probably wouldn't have been so detrimental to me. But because of the previous sort of strains and things that happened perhaps to my tissues, it's now not as strong to take that load.
Right.
Welcome to Breast Intentions, the podcast where we take off the bra of expectations and dive into honest, empowering conversations. We're your hosts, Nadine and Cynthia, 2 Canadian girls who swapped snow boots for flip-flops in the Cayman Islands. This is your space to feel seen, supported, and a little less alone. So grab a cup of coffee or a glass of champagne and get ready for your weekly handful of truth, wellness, and empowerment. Welcome back to Breast Intentions. Today we're joined by Elzke for part 2 of our pelvic health series, diving into what happens when pelvic prolapse becomes a reality, from symptoms and treatment options to recovery, support, and getting your confidence back. This episode is an empowering conversation every woman needs to hear.
So in today's episode, we have Elzke, who is a pelvic health physiotherapist. Welcome to the show.
Hi, Nadine and Cynthia. Thank you so much for having me on your show.
Well, thanks for coming on. Now, if anyone has watched, or if anyone is going to be watching this episode, what they may want to know as well is that we have done a part 1 with another pelvic floor physiotherapist. And so this whole podcast and this whole episode is really about, I now have pelvic floor issues. How do I deal with them? Who should I talk to? What should I ask for? So we're really glad that you're on the podcast and we get to chat with you a little bit more. But for any of our listeners who may not be familiar with you, can you give us a little bit of a background on how you ended up on the island, how you ended up as a physiotherapist?
Yes, absolutely. Well, in my youth, I was an avid athlete and sports enthusiast, and I have a passion for medicine and for helping people, and that made physiotherapy quite a no-brainer and an easy fit for me. And while I was living my best life, and as you do in your 20s, we decided to travel the world, and Cayman kind of just was the place that drew us, and I've been here 10 years now, and we've been enjoying the island, and I've been privileged to help many people here with my skills and so forth. But as I was participating mostly in sports and orthopedics physiotherapy, naturally, I was exercising and living my best life. And sadly, kind of in my late 20s, I developed pelvic floor dysfunction. And that kind of took me by surprise, as, you know, these symptoms of pelvic floor dysfunction just occur and you kind of feel, oh, what now? And I realized that I needed pelvic floor physiotherapy as a result. And back then that wasn't so easy to come by. And so I very quickly enrolled in my postgraduate certification in pelvic health physiotherapy. And that really helped and changed my personal life, as well as the way I practice every day. And as very much as a patient, you can often feel alone. And I don't know if you guys have done a mental health podcast about pelvic health, but often that affects your mental health as well. So
we did kind of talk
touched
the confidence
on it a little
side.
bit.
Yeah. So I'm luckily positioned in a place where I can contribute to these people's quality of life and help them from my own experience as well as expertise.
Good for you.
That's
You're
great.
doing some great work down here. I'm just going to get straight into the question. So what are the most common signs that something is wrong with the pelvic floor? Like, even for you, like you were saying, in your late 20s, what were some of the signs that you noticed?
Yeah, so personally, I developed as an athlete a lot of pelvic pain at the time, but it was associated with some urinary dysfunction, sexual dysfunction, bowel dysfunction, a whole triad of things. And often these symptoms can be complex. It's not just one area like bladder or bowel that are affected. But I think if I could take a little detour, it often really helps to understand the function of the pelvic floor before we look at problems such as dysfunction, right? So the pelvic floor is a little hammock shaped muscle at the base of our pelvis, and it governs sort of your urethra for urinary function, vagina for sexual function, rectum for bowel function. And then it has a great function in organ support, like holding the bladder and the uterus and the bowels up. And so that it does a lot for a group of muscles that we do not think about until something goes wrong.
Yeah.
You know, like myself. And so dysfunction often looks like things that interrupt those systems. So unable to hold your urine in, unable to pass urine smoothly and normally, so urinary retention, pain with intercourse, pain with any sexual function really, bowel issues such as continence, keeping stool in, constipation, straining, pain with defecation. And then often when it comes to the organ support part, patients would report things like feeling pressure, dragging, discomfort in their pelvic area. So like I said, the pelvic floor is the unsung hero. It does heavy lifting, and we don't think about it until it really fails us. So those would be the things that would show up.
Okay. So this part of the symptoms.
Yes.
Yeah. And I'm sure we'll probably get into more.
We'll get into yes, for sure.
Okay. So when we're talking about pelvic floor, what does pelvic organ prolapse feel like, and how do women typically describe it?
Yes. Okay. So I see patients like that every day in my office, and they often complain of a feeling of pressure and discomfort. Sometimes it starts like over their lower abdomen. Other times it's in the perineal area or in the sort of vaginal area. And they will report symptoms sometimes like feeling that something is there, like a little ball or like a tampon is inside of them and partly coming out, right? And it can be painful. They'll often say that, oh, I feel something there. There is a little ball-shaped thing that wasn't there before. Or I took a mirror and I looked and I see something there and it wasn't there before. And these symptoms can often be reported as aggravated with long-standing, like after a long day when gravity has really done its work a little bit. And after exercise or heavy lifting, that might be aggravating factors for these symptoms. So you might wake up feeling pretty good, but by the end of the day, you're just like, why is this so heavy and uncomfortable? And what's happening to my pelvic floor?
Oh, okay. So this is more, did you mean like they can feel a ball?
So yes, sometimes they don't, depending on the stages of prolapse.
Right.
But very often, if you, at the entrance of the vagina, there might be a little bulge. Like a little, almost like a cyst-like feeling or a little ball feeling.
Oh, okay.
But maybe not if it's still early.
If it's still early days, they might not feel that at all. So I kind of grouped all of these together of how they can present. But depending on where they're at, they might not feel anything palpable or see anything.
But they still might feel
might feel off and pressure and that sort of heaviness is the right word.
I almost feel like that like
you guys
is that also like a feeling of like just heavy cramps for a woman?
I personally haven't had these symptoms, so I think it could be a similar type feeling. I actually had a patient this week, and again, who it started out more abdominally, which we don't always think pelvic organ prolapse when it starts out abdominally, right? So it actually it was delayed in diagnosing it because she did go and seek some assistance, and it wasn't diagnosed because that was kind of not so typical. But yes, I think it can present itself like some cramping, and just I think sometimes women are very intuitive. And speaking to her, that something's off.
Yeah.
You know when something is off.
Right.
So
okay.
It's usually not an acute pain and sort of, you know what I mean? It's quite a nagging, dragging discomfort rather than sharp and acute.
Okay. And then will it start to just like become worse and worse in the pain area, pain level, or?
I think it's, just to backtrack a little bit, sorry, it's important to note it could also be associated with changes in bladder function, depending on what organs are kind of losing their support.
Okay.
And also changes in bowel function. And that might be the only symptoms that you see. So just to point that out as well.
Okay.
So it's not necessarily that it's going to get quickly, exponentially worse. But it is definitely something that I would say needs attention, because it points that the support system of the pelvis is now not doing its job like it should. And if we continue just down the same road and do the same things of our daily life that we did, that kind of brought this about, it could potentially get worse. And kind of pausing and assessing and finding the right assistance might change the course of how it can develop.
Right. Let me ask you another question as well. Do a lot of your clients come to you because they have noticed something, or have they seen their like gynecologist and then it's been referred over to you?
Yeah, so that's a great question. It's a mix.
Is it?
So some patients, and in today's world, we thankfully have so much information at our fingertips, right?
Yeah.
You put your symptoms in, something spits out an answer, right?
Maybe some answers that you also.
Yeah, exactly, right. So, but it helps direct at least who you need to call in the morning, right?
True.
So it helps tell you who to call. So I definitely see, as a first line practitioner, patients in my office where they haven't seen a specialist, and vice versa. Sometimes somebody would not feel very comfortable with these changes in their body, and rightfully so. And they would call their general practitioner or their gynecologist. And it can really go either way. And we work hand in hand. If I see a patient and I think they need to be seen by their general practitioner or gynecologist to make sure that there's nothing sinister going on, or that there isn't something more to this, and it really is just what it is and can be dealt with in my office, I will refer them immediately. Yes. And if they get seen vice versa by their gynecologist or their GP, and pelvic floor therapy forms a part of their rehabilitation, they would get referred.
Okay. Now, with this being kind of the second part series, and we're talking more about, we now have an issue, what are some of the red flags that really do mean that like you need to see someone, whether it's a gynecologist or you? What are some of those red flags?
Yeah. So again, just to highlight, like any changes, I think women put up with so much that we want to wait for red flags before we get help. Yeah. And really in this stage of life that women are going into, we don't have to accept that as normal. So there don't have to be a red flag to kind of get early assessment, early intervention, and better outcomes. When it comes to red flags in medicine, those are things that we kind of are more serious. Now we need to like escalate this a little bit and maybe see a professional. Luckily, on the topic of pelvic organ prolapse and pelvic floor dysfunction, like urinary dysfunction and so forth, there are very seldomly emergencies where things are sort of, okay, now we're going.
Okay.
But I would want to encourage anyone listening to this that if they have symptoms like we've discussed about prolapse or any of these dysfunctional symptoms associated with bleeding, like in their blood in their urine, or bleeding that isn't normally related to their period, or blood in their feces, or if they have fever associated with these symptoms, or if they have a sudden loss of bladder or bowel control, right? So, I've lost complete control of my bladder and this has never happened before. Or that they cannot empty their bladder, so urinary retention. Those would be definite. Call your doctor and go and see them.
Okay. Now, going along the lines of the urinary side of things, so that like sneeze where you kind of pee, or the, quickly running, or you're skipping or something, and there's like a little bit of peeing happening kind of thing. Is that like a sign right at that time to be like, I need to go and talk to someone? Or is that more of like, I'll just give it a little bit and maybe I'll do some Kegels and then, see if it continues to still happen?
So you mentioned symptoms of stress incontinence, super common in the world of pelvic health. And
super common, I think,
super
among
common
women, especially if they've had children, right?
And again, how many patients come and say, I've had leaking with coughing and running and jumping since I had my first baby 25 years ago.
Right.
And women are resilient and they put up with a lot, and we often label things as normal after childbirth or normal during menopause, or just, getting on, just trotting along and focusing so much on our families and on our careers and life, and kind of shifting that a little bit to the back of our minds. But I would definitely say yes to your questions, that should be a sign that your pelvic floor support system isn't able to take the loads and the pressures that you're applying to it day to day, and it is failing a little bit. Now, you mentioned Kegels. So very often, we think that, I have urinary leaking and my pelvic floor is weak, and therefore I need to do 1,000 Kegels.
Yeah.
and that is not the case, right? So it's important to understand that pelvic floor and urinary dysfunction issues can develop not just from a weak pelvic floor, but also from a tight pelvic floor who's struggling, right? A pelvic floor that isn't working at the right timing, so timing becomes important. A pelvic floor that just has been under excessive load, like a chronic cough, like I've had for the last 2 months. My pelvic floor suffered significantly, right? So, and sometimes you do not need to do Kegels. You need to make some lifestyle adjustments, or you might need to do a different set of exercises as opposed to Kegels. And that's why early assessment and individual care is super important, rather than this is a cookie cutter, I leak, I do Kegels. I wish it was that simple, but it isn't. And sort of having somebody help you and guide you through what exactly you need to do to resolve those symptoms, I think, are super important.
So then, going along the lines of what you were saying about the coughing, and the little bit of the struggle as well, do you just leave that until you start to feel better? Like, is there anything that you can do when a person has a cough? And
why would a cough put strain on our pelvic floor?
I think you two can hear now. I always take a back road, so let's pedal back and explain, and then see how we got here. So the pelvic floor, basically, not just the pelvic floor. If we look at the pelvic floor in isolation, we're definitely missing some things. Right. But we want to look at the pelvic floor and the pelvic support system, right? Okay. That consists of ligaments, tendons of other muscles, the pelvic floor muscles, the pelvic fascia, right? Which are like very strong connective tissue fascia that help support the vaginal walls and the organs and so forth. They're like a dynamic scaffolding holding all of this together, right? And it takes load constantly. Like every time you run up the stairs, every time you cough, every time you move, this whole thing is kind of moving as well and under strain. If you go to gym and do your little weight training, if you're pregnant, my goodness, right? So the scaffolding is doing serious job, right? So if you have something like a chronic cough, the load and the impact that's going through the scaffolding sometimes is just a bit too much, right? And it fatigues and tires and gets strained, right? Yeah. Imagine carrying a heavy load on your back.
You're straining, you're
straining
tensing,
and tensing.
Yeah, using all those muscles.
So those muscles fatigue, or they become really tight, because incontinence is embarrassing. So they're like, whoop, we're not going to let this happen. So they clench for dear life. And that's dysfunctional. So then they can't hold the urine in because they're trying too hard almost in a way. So that's why things like a chronic cough, it just excessively loads the system, and the demand becomes more than the capacity
Right.
for load. And that's where we see dysfunction. That's where any dysfunction is going to kind of start developing. Now,
So like, what do we do about that?
Yeah.
We need to cough.
yeah. So one normal coughing is part of normal life, right? We're never going to not cough. I think it's important to also say with dysfunction like this, it's often not one thing. It's often not your cold and the coughing associated with that that's causing pelvic. If we can use myself in this example again, like some pelvic floor muscle issues due to sporting in my 20s, then 2 babies later, and so it's like adding stripes to a tiger a little bit. And then I was sick for the last month, so that coughing probably wouldn't have been so detrimental to me, but because of the previous sort of strains and things that happened perhaps to my tissues, it's now not as strong to take that load.
Right.
So what can we do? Like, obviously we do need to cough. Sometimes it's good to learn techniques to cough. If you have a chronic cough, it's good to see somebody like myself to understand what is your pelvic floor doing and how can you optimize its function so that when that happens, right, you have the capacity to meet the demand, right? That's what you want to work on. And then a multidisciplinary approach is always important. If you have a chronic cough, you need to go to your GP and talk to them and sort out your allergies and figure out how do you decrease the load on the system. You don't just hack away, because eventually that load will become too much.
Right. That makes sense. It's really just getting to the root of the cough, right? The root of the
Understanding,
issue. Yeah. Okay. So then looking at pelvic floor dysfunction or prolapse, what are the most common causes? Now, one of the things that I was going to say about this too is someone I know. Someone I know.
Can we name them? Is it Cynthia?
No. I was
Friend of a friend.
Yeah. Actually, it's my mom. And she'll probably be fine with me saying this. But she has the bladder prolapse and in Canada, and basically was given a video to watch when she was diagnosed with it by the doctor. And my mom was saying, in this video, you are actually the person that is blamed for why you have the issue.
Well,
So it was very, very disheartening.
that must be terrifying as well.
Yeah.
Like,
Yeah.
I mean, I don't think an individual can ever be blamed, right? Because also tissue, we just talked about the scaffolding. Tissue integrity can be genetic, right?
Yes.
These things can often be genetic. So some tissues are more lax and more easy to, like, susceptible to stretching and being floppier. Other tissues are more susceptible to be rigid. How are you, like, if your mom was pregnant with you, how was she going to be in control of how that baby grew and what happened to her pelvis and birth? So I think that's actually very sad. Again, it leaves patients with mental health. The mental health components of this can often be debilitating because they feel alone and isolated and well, some mostly just because of their symptoms, because it's changing their quality of life. And you don't want to go out and dance your heart out with your friends if you're weeing your pants, right?
Or laugh.
But in your mom's case, that video also just made her feel sort of, disheartened, which is not what healthcare should be today.
So genetics is one of the causes.
Sorry, back to your question.
No, it's totally fine.
I got carried away by the sad.
Yeah, I know, right?
It horrifies me. So you're just repeat your question. Sorry, Nadine. What are the common causes of prolapse?
Yeah.
Right. So back to my scaffolding theory. Anything that really affects these struts can cause prolapse, and it's very seldomly one individual thing. Occasionally, someone will have childbirth, and that will cause prolapse. But it's often, like I said, stripes on a tiger. It's the cumulative load over time. So hypothetically, a runner who's jogging a lot and doing lots of weight training, so things that have impact, but that doesn't mean we shouldn't run, right? Or shouldn't lift weights. I'm not saying that. I'm just saying sometimes we do we lift too much weight that's appropriate for us, or we don't necessarily do them correctly, right? And over time, the load accumulates. Pregnancy and childbirth are major contributors to this. Things like I mentioned before, chronic coughs and other conditions can sometimes contribute to this. And then I think menopause is a big contributor. Now, menopause doesn't necessarily directly add to the top-down load. Like you can see running, weightlifting, and all those things kind of have a structural loading. What menopause does, and as estrogen lowers in our body, estrogen can be seen like this tissue maintenance hormone for the pelvis, right? And it helps to keep the tissues kind of thick and flexible and supple and strong, right? And gradually, as that decreases, the tissues become a little more fragile. So the dynamic struts, the ligaments and things, are a bit more brittle, a little drier, a little thinner, right? So less load is required for the system to collapse, essentially, right?
Makes sense.
So menopause definitely is a major contributor. And you often see these patients kind of like myself, pelvic floor dysfunction, younger, perhaps pregnancy, childbirth, and then estrogen disappears and we don't necessarily do HRT or help the tissues in that way. And then the pelvic organ prolapse shows up.
And I think we may have talked about it with in a different podcast, but is it HRT or can it also be the vaginal estrogen? You can use that, right, to help?
Absolutely, yes. And that's
So then
a great
for
support.
a lot of women who are, because I think we talked about this with Heidi, for women who may be like postmenopausal, who are now having the incontinence and that kind of thing. That's why Heidi was saying that she's like all day, every day, she'll prescribe that for a lot of the women because
of what I've just kind of explained, what happens to the tissue. So, I mean, I am not an expert on prescription and advising on vaginal estrogen and HRT and all of that. Heidi and other women's health doctors are fantastic at that. And that brings me back to my point, multidisciplinary team. You can do you can do your 1,000 Kegels. But if your tissues that don't Kegel, the ligaments don't Kegel, are brittle and weak and not necessarily thriving, you're still going to have a hard time managing that load distribution. So yes, I would say definitely if this is something that somebody is like thinking about right now as they might be listening to this, they should talk to their physician and get somebody in their corner to help them through this.
And I think one of the things that we've realized now with this being the second podcast is Kegels are not...
It's not the answer.
No.
And even if it can help, it's not always the end of the answer
it's
either.
Not, like, it's definitely not going to solve all your problems.
No.
Which I think
defense.
I think a lot of
women, I think that's the go-to. Like,
But in all of your defenses, pelvic health physiotherapy specifically has come a long way
for sure
in the last decade, right? So they used to prescribe these Kegels to women left, right, and center, and we're so grateful. I'm so grateful that we live in an era with just better ways to do research, better ways to get these answers, and that we can sort of admit that maybe we weren't correct. And move along swiftly.
Okay, so now we've realized that maybe something's wrong and we need to see a pelvic health physiotherapist. What happens during a pelvic floor assessment?
Excellent question.
Yes.
I love how it said they demystify.
Let's demystify the process, yes.
Well, it depends how much NCIS you've watched. I'm kidding, in the sense that it's a very detective process.
Okay.
Like we always look for culprits, what's causing this and so forth. I'm joking. Anyways, to be more serious, a patient would come and see a pelvic floor therapist, and it would definitely be a very sort of private conversation and exam in a comfortable setting, right? So first and foremost is sort of a subjective examination. So talking to your therapist and getting a very good understanding of what exactly are your symptoms? Because as you can see, pelvic floor dysfunction is so broad.
Yeah.
It can cover so many parts, as we've now discussed. And you also really want to dig deep into how we kind of got there. What is someone's history? What kind of led to this point? And also maybe their family history. We just talk a little bit about genetics and so forth. So I always say that like that's sort of where the gold is in a pelvic floor assessment, is really getting an understanding of that person as a whole. Do they have sinusitis? What does that have to do with pelvic floor? They think I'm nuts. Why are you asking about my sinus? But until they learn how this really affects them.
And?
So no, just like the coughing and the sneezing and all
so
of that loads the pelvic
you're
floor.
Getting the postnasal drip?
Yeah. So we want to be able to refer and kind of, we want to work on decreasing that load, right? And managing that. So that would be the first part of the exam. The second part would be more what we call an objective exam. And that's kind of looking, feeling and moving, right? And everybody thinks we're just going to dive right to the pelvic floor. But it's important to note that the pelvic floor works in a system in the body, right? So how we're breathing has an effect on the pelvic floor. So we would look at how somebody is breathing, how you're doing your squat and your lunge and at the gym might be affecting your pelvic floor. So we would do a movement examination. Your lower back pain and hip dysfunction might be affecting your pelvic floor. So we're going to look at how's your lower back and hip mobility, strength, and so forth, which are all non-related to the pelvic floor. So a lot of the exam is not very much focused on the pelvic floor, but acknowledging that the pelvic floor is a part of this more holistic system. And then lastly, well, not lastly, but we get to the part where we occasionally have to do an internal pelvic floor exam. Now, that doesn't have to be done. If a patient doesn't want to do that, we can gain a lot of information from the things that I've just said, and we can still attempt to help. Sometimes it is necessary to assess the pelvic floor muscles, and that would be an internal vaginal exam. And if you think of any muscle assessment, if you've ever been to physio, it's kind of feeling, what do these muscles feel like? Are they tight? Are they floppy? What's happening to them? And then also kind of seeing how are they moving? So what is your Kegel doing? Essentially, can be rated. No, I'm kidding. How are those muscles working? And then how are they responding under strain, like a cough? And can they relax? And how are they functioning? And then that all together kind of makes this picture of support structure, capacity compared to load. And then we can see where we need to start working.
Is there an easy way to let people know when is a good time to go see a physiotherapist, pelvic health physiotherapist, versus like say a gynecologist or I guess a physician?
Yeah. So it's tough. It's a tougher question. Sorry. It's not clear cut.
Yeah.
Like X symptoms equals pelvic floor physio, Y symptoms equals visit to gynecologist. And these things are quite overlapping.
Right.
I guess, as I previously mentioned, if the symptoms are new and you feel very uncomfortable and unsure about what's happening to your body, and they might be persistent or more leaning towards the red flags we've discussed, definitely visit your gynecologist first. If you are familiar with your symptoms and you kind of intuitively know you should be seeing a pelvic floor physiotherapist, and you can say my symptoms have clear aggravating factors. They're definitely worse when I run, or they're definitely worse with intercourse. That might point more towards perhaps starting with a pelvic floor therapist and then maybe getting referred to your gynecologist or GP, etc. If we think a more multidisciplinary approach like vaginal estrogen or so forth might be necessary.
Right. Okay. So we've talked a little about Kegels. Are there other effective non-surgical treatments
To pelvic floor.
to pelvic floor?
Yeah. again, it's very broad when we say just pelvic floor dysfunction, right? So sometimes if let's say just in some patients, their dysfunction can easily be managed just by some lifestyle changes. They didn't even realize they were doing these things, bothering their pelvic floor, and just stopping that can sometimes already be a winner, right? Other times, like in pelvic organ prolapse, there is more work to be done, right? So it can vary on a range of what needs to be done. But things like lifestyle modifications and changes, focusing on bladder and bowel habits and how we're going with that, and just being educated on that topic can be very useful. Then again, looking at movement as a whole and not just Kegels. So exercising appropriately, breathing appropriately can be very helpful tools. Things like pessaries can really be helpful in pelvic organ prolapse as a non-surgical tool. Very, very helpful, improving women's quality of life. And working that with pelvic floor physiotherapy can often provide great results.
Right. Well, we had Robin on the podcast, and she had, was it called triple organ prolapse?
I think so.
And it happened after giving birth to her twins. And it was, do you have twins?
No.
Oh. I was like,
No, thank you.
and so she.
Sorry for my shock. I still have young babies, and twins scare me. You just scared me.
And she used a pessary.
Which, yeah, she said she didn't feel like it was fitted properly.
Yeah.
So she didn't find it helpful. And then just didn't bother didn't go back to sort of let them know it wasn't. So she just stopped using it.
And
Did
I
she
think
have surgery in the end?
she did. We actually did the podcast with her 7 weeks after the triple organ surgery. Okay. Yeah. But very much changed the quality of her life. Like where she was saying that her husband bought her a bike to ride with her kids. And she's like, I can't sit on the bike.
Yeah. And you make a very valid point. Like pelvic floor dysfunction has a direct impact on women's quality of life.
100%.
And we, again, I always wonder how they've been putting up with it sometimes for so long.
Yeah.
Well, because we talked about this on the part 1 of the episode with Danielle, where it's these taboo kind of topics. Like women don't want to talk about if they're peeing in their pants or if they're pooing when they're not supposed to be.
I think now better, and you two are trailblazing this for them. Good. Doing this podcast. Women should be talking about this, but it is kind of taboo topics. I think 10 years ago, no one mentioned this, but we're slowly coming through that, and more women are talking about it.
Definitely.
And I'm so just happy because someone's listening to this that needs to hear this. And
for sure.
Yeah.
Well, and I think I maybe said it on one of the last podcasts, but I know of a woman who had 3 babies back to back, and even like laughing, running, she couldn't do any of that, and ended up having the surgery, very successful. And the comment was made to her after the surgery by one of her kids that they had never seen her laugh because she couldn't. And so like thinking about how much that affects the quality of your life, right? Or not being able, like Robin, not being able to do certain things with her kids because you can't run, you can't ride a bike.
But doesn't that also just point to, like, she probably didn't even notice her kids never seen her laugh, that how good we are at compensating and buffering for that. She probably got on with her life and just didn't laugh and didn't make anything of it.
Yeah, agreed.
And so women are resilient and just compensate for it left, right, and center.
Right.
Yeah, definitely.
Yeah.
I just want to go back for a quick second.
Yeah.
The lifestyle changes.
Oh yeah. Yeah.
What
are they?
What are some of those?
So, I mean, again, wide, broad topics, but let's start. We can touch on a few for sure. Let's say you have chronic constipation, right? And you are straining every couple of days to have a bowel movement. You might want to look at your nutrition and your diet. And again, that multidisciplinary team approach comes into hand, and to improve your stool consistency so that there's less strain on your pelvic support system, right? That could be one of them.
Right.
Silly things. Sometimes patients complain of frequent waking to urinate at night. And again, sometimes we're so busy in our day with kids and school drop-offs and or work or whatever we're doing that we don't hydrate well in the early parts of the day. So something as simple as just hydrating well in the early parts of the day and not towards the end of your day when you're feeling really thirsty or maybe exercising can already improve your frequent night urination waking. So just critically looking at what you're doing.
Yeah.
Can
we talked a little bit about
already
this
make changes.
in the last one too, about
I'm guessing,
some bad habits that
I
for sure have. And before talking to Danielle in episode 1, I didn't realize these were bad habits. Like where I'm in a hurry and doing like the power pee and trying to pee as quickly as I can was one of them. But I don't think we realize that these are bad habits or that they could over time accumulate and have an effect because I feel fine now. So
yes. So like I said, sometimes you need more extensive rehabilitation and multidisciplinary approach, but other times a few simple things can really have a big impact.
I think as well, some of the work that you're doing, I don't even know if I realized how much it's not just the physiotherapy side of things, it's the conversation where you're going to meet with someone for 45 minutes or however long, and in that amount of time is an opportunity for a woman to talk about herself, right, where we don't really get to very often.
That is so what I'm there for. I love that is literally the part of my job that I love. Like they can just be seen once for every little part. And back to the little mental health part that I keep bringing up a little bit, because I think I just see so many women in my office, and not even just related to their pelvic floor dysfunction, but somebody under a lot of stress. Again, we don't have to unpack that in the session, but can be such a big contributing factor to pelvic floor dysfunction. And just like getting it all out sometimes is very helpful and a good starting point, and for someone just to be seen.
Right.
If we think, I might think about it in a range from like these pelvic floor dysfunction to prolapse being a bit more serious. Can these things actually be reversed, or is surgery kind of the only option?
It's a very good question. It also has many parts, as you can see with all these questions.
Yeah.
But I think, as previously mentioned, very, very few times in pelvic sort of dysfunction, as we've been talking about it, is there sort of emergencies, right? So surgery doesn't have to be right now. So often what we would recommend or so forth is that conservative therapies be attempted and give it a good go. And so if your conservative therapies and your changes that you've now made is still haven't improved your quality of life and given you your confidence and your comfort back, then perhaps surgery might be the next option, similar to Robin, right? Maybe pessary wasn't quite working out. Yeah. She tried the conservative way and it just didn't cut it, right? So then surgery can be on the table. Now, pointing to can conservative therapies actually reverse the dysfunction, we're going to break it into two parts. Sometimes when it's just not pelvic organ prolapse, so this basket of dysfunctions that we sometimes point towards, yes, we can significantly improve the symptoms that somebody is experiencing and improve their quality of life, and we would consider that success. When it comes to pelvic organ prolapse, again, it's a little bit more complicated than that, and patients ask me this very, very often. So small prolapses, right? Yes, we, again, improving the things we've spoken about without repeating myself can improve that. If you start with, in Robin's case, you have 3 different kinds of prolapses, the support structures of the scaffolding have now failed a little bit. You've maybe torn a ligament, the pelvic fascia has strained and weakened significantly, that the organs are no longer supported. Pelvic floor or conservative therapies can, in those cases, still improve somebody's function and quality of life, but they cannot restore the anatomy to where it needs to be, right? And on the same topic is that tissue damage isn't always directly proportional to dysfunction and symptoms. You sometimes see patients with severe prolapse that have minimal symptoms. And other times you see patients with small prolapses that are very symptomatic. So in terms of, I hope that answers your question somewhat, but it's very much a symptom quality of life thing that we want to ask ourselves. Can you live your life and enjoy it in the way that you would like?
And most people are coming to you because it's affecting their quality of life.
100%.
Okay, makes sense.
So when surgery is necessary, is there anything that women should know before considering that?
Yes. Yes, I think so. I think, knowing that there are conservative therapies out there, right?
Okay.
So if they want to try them, some patients are not eager to just go for the surgery, right?
Yeah.
So knowing your options, I think, is always a good thing. And then if you want to try some conservative therapies before having surgery, so that's always very good. And then also, if you decide to have the surgery, I think it's important to speak to your surgeon, gynecologist, urogynecologist, etc., and understand the risks of the surgery and just also the success rates of the surgery. Some surgeries have a higher success rate than others, depending on the anatomy involved. And sometimes revision surgeries are needed.
Oh, okay.
And so I think just like everything in this field, but specifically surgery, should always be discussed on a case-by-case basis.
Right.
What's your tissue looking like? What's your life looking like? What are you going to do after this surgery? Are you going to, be the next trampoline gymnast? Like, what are you going to do once you've had the surgery?
Yeah.
And then I think my last important thing for surgery is, what are you going to do after the surgery in terms of rehabilitation? Because
I was just going to ask.
That's our next question.
Sorry, guys.
No, that's okay. Exactly. Let us right into it. What does recovery look like? How long does it typically take to see improvements?
I'm going to get back to you on that in a second, but it's important to note that the surgery is going to help strengthen some of those connective tissues, repair some of the ligaments, get your scaffolding back. But if you're still overloading the tissue, right, and you haven't kind of helped the support structures through the pelvic floor, which we have more control over, your surgery is not going to be necessarily has the longevity that you would like it to have. Yeah. So sometimes we think, stitch it up, put it back together, and off we go.
Right.
But then we haven't looked at the lifestyle factors and the load on the system. And that should be very much looked at sometimes prior to surgery and after surgery. Yeah. And that's where we kind of play a role as well.
Yeah. Well, or even, for instance, like chronic constipation.
Yes.
Right? If you haven't solved that after you had your surgery.
It's detriment. It's actually, it's sad, and that's not good. Like, you want to, if you are going to have the surgery, you kind of want to make sure you've ticked all your boxes so that you can get the best quality of life out of that surgery. And again, that should all be assessed on a case-by-case basis, because no two women are going to be the same in any of these situations. Yeah. Sorry, did I miss something?
Recovery. Just like
what does it look like?
How long does it take? Like, what does the recovery look like, and how long does it take to see improvement after surgery?
So after surgery, I mean, surgery is often very good at correcting the anatomy, as we've discussed. So very quick after surgery, women can see improvement, right? Especially if we're talking about post-op recovery, right? Because the bladder is sitting where it should sit, the rectum's gone back, the uterus is maybe removed, so no longer part of the problem. So patients often feel much better. I think the recovery comes more into the long-term factors, right? And again, sometimes that can be resolved pretty quickly. Other times somebody needs more extensive rehab and return to exercise. And that's also going to depend on the patient's goals. What load do they want to run a marathon? Okay. Well, we're going to have to do a lot more work to be able to tolerate that load than somebody who just wants to enjoy their life and trot along.
Yeah.
Right. Yeah.
What's the biggest misconception women have about pelvic floor issues that you wish you could change?
I think we've covered at least one of mine. Is that obviously Kegels does not fix this problem.
Right. Yeah.
And I guess just if you have a pelvic floor problem and you want to address it, get some professional advice and get it addressed properly and get an individualized approach for you. You're probably going to get the most out of it. Mm-hmm. So skip the Kegels, get down there, figure out if you should be doing them or not. Right.
Yeah.
And then I guess the other misconception is that, and I'm sure that's why you guys are talking about this, is that this is not normal. Mm-hmm. Pelvic floor dysfunction shouldn't be accepted as part of aging, as part of postpartum recovery, as normal. Mm-hmm. And we can be informed, and and like I said, there's not even just one professional that can help you. There are many professionals who can point you at least in the right direction to getting help and improving your quality of life.
Right.
Yeah.
Anything else that you think that
do we miss anything
you want to discuss? What's your thoughts on the high fem chair?
Oh, Emsla. Come on. That's an easy question. We've answered it repeatedly. How are 25,000 Kegels going to solve any of these problems?
Right.
We've answered that question, I think, enough here. Yeah. And again, like, I think, back to misconceptions, I think occasionally a lot of women come to my office. They've already concluded that Kegels might not be the answer. They already know they have a problem, so they're already there. And they already want to empower themselves. So we've ticked those boxes. But they often think that, the pelvic, I'm going to just examine their pelvic floor. And when we think about those high fem chairs, it's just addressing the pelvic floor. It's not looking at the patient as a whole. Mm-hmm. And it's also not looking at the patient and how the patient engages in their environment. And environmental factors here play a huge role. Mm-hmm. So I think we're missing so much of the puzzle. And that's just one piece of it. Do I say that someone cannot benefit from that? Absolutely not. But you need to know if that's right for you.
Mm-hmm. Right. Is there anything else out there that you've seen people come in and tell you about, and
sort of technology wise,
or even just like old wives' tales or anything like that?
Oh my, yeah.
Oh really?
Yeah. Well, you guys must be familiar with this, but a lot of misconceptions back in the day, along with the Kegel misconception, was that you should stop the flow of urine midway.
Yes. Oh yes, you're right.
My goodness. And I mean, my heart stops kind of in my chest every time somebody says that. Yes, I stop my flow of urine midway every time I wee. And I'm like, hardly why you're here. And so that is such a
that's doing more damage.
That's doing so much more harm than good, right? We need to get that out of the books, rewrite those books. But
no way, okay.
Because it's trying.
Because we think, or we could potentially think that it's helping to strengthen it.
Yes.
And it's actually making it weaker by...
It's not making it weaker per se, but the brain and the pelvic floor work together, right? So the pelvic floor is super complex as well. And the whole body, your brain works with everything. So you're basically training your brain that you should tighten your pelvic floor muscles when you're urinating, which you should not. You should relax your pelvic floor muscles when you're urinating so you can empty your bladder completely. And then patients end up with things like not fully emptying their bladder, urinary tract infections, overactive bladder syndrome. So we're really messing with the communication between the brain and the bladder there. Yeah. And so we need to get an end to that.
I don't even know where we would have learned that from. I do remember hearing
I
it.
know,
though.
me too.
Yeah, I do. There was also something else that you had brought up about like the really heavy lifting. And I know you're saying like you're not trying to tell people to not lift heavy, but I'm assuming it's more in terms of like how you brace yourself.
Yes.
And how you breathe.
There's a couple of factors I think that implicate heavy lifting. And I'm actually just thinking about a patient I saw recently. I mean, when we're going post 40, right? We are being bombarded with eating protein and weightlifting to counteract the changes of bone health and muscle health, right? And that is rightfully so. But sometimes some women just, they haven't exercised in the last decade. And now they want to make up for it a little bit. So they're perhaps starting too eagerly.
Yeah.
And they are sort of imminently overloading tissues that haven't been stressed and loaded for a decade, right? So the tissues are not kind of resilient and ready to take on that load. So very quickly that can result in an overload, right? So, and I can see that even for myself, you kind of have 2 children, you never have time to exercise ever again because you're just trying to survive. And then you can see when they kind of sleep through the night, here we go. We're going to hit the gym, right? So it's a very common, I think, pattern. And so that could be part of it. And then there is the element of not breathing properly, not bracing or using your whole body properly to do the technique. And obviously repeatedly doing that overloads the system.
Again, another reason for why when you're doing your assessments, that one big part that you were talking about is like understanding how a person's body moves. Because if this person every single time does something, I'm not really sure, but like holds their breath and they can learn how to not do that.
And that can make such a big change, right? Just take like basically unloading the repetitive strain that we do to the pelvic floor.
Right. Yeah.
Sometimes most of the time, in your mom, like no one's harming their pelvic floor consciously.
No. No.
It's that we're not realizing that some women might even not be aware that they're holding their breath if they're doing an exercise. It's an unawareness thing.
Yeah. Yeah. Well, this is great.
This is great.
Yeah.
Learned so much.
It was. Thank you for coming on.
You guys are so welcome. Thank you so much for having me and keep doing what you're doing.
Yeah, thank you. For anyone who does want to come and talk to you, have a chat with you, book an appointment with you, how do they get in touch?
They will see it will be a very long talk as established. Anyways, so yes, they can find me at Elevation Health and Physiotherapy, and they can just look up elevation.ky. And my details will come.
And they don't need a referral.
This is an insurance-based question, so depending on their health insurance, they might need a referral.
I see.
But they could come and see me, and we can establish the administrative details from there.
Got it. Okay. Well,
Thank you
very
guys.
much.
Thank you.
Thank you.
Thanks for joining us on Breast Intentions. We hope you felt seen, supported, and maybe had a few laughs along the way. Don't forget to share, subscribe, rate, and review us. Your support keeps the conversation alive. Follow us on social media for more insights, behind-the-scenes fun, and updates on future episodes. Got a topic you want us to dive into? We'd love to hear from you. Remember, life's too short for bad bras, toxic relationships, and kale you don't actually like. So until next time, stay bold and keep your breast intentions exactly where they belong, front and center. Now go crush midlife, or at least today's to-do list. Cheers!